We are now continuing on with part 2 of the Neurological Alterations lecture, and we're going to start off with Guillain-Barré syndrome. So, Guillain-Barré syndrome, once thought to be a single entity characterized by inflammatory peripheral neuropathy, is a combination of clinical features with various forms of presentation and multiple pathological processes. Most cases of Guillain-Barré syndrome do not require admission to the critical care unit. However, the prototype of Guillain-Barré syndrome, known as acute inflammatory demyelinating polyradicular neuropathy, or AIDP, involves a rapidly progressive ascending peripheral nerve dysfunction, which leads to paralysis that may produce respiratory failure. Because of the need for ventilatory support, AIDP is one of the few peripheral neurological diseases that necessitates care in a critical care environment. In this discussion, all references to Guillain-Barré syndrome pertain to the AIDP prototype. The annual incidence of Guillain-Barré is 1.8 cases per 100,000 persons. It occurs more often in men and is the most commonly acquired demyelinating neuropathy. The cause of Guillain-Barré remains unknown, but the syndrome involves an immune-mediated response involving cell-mediated immunity and development of immune globulin, or IgG, antibodies. Most patients report a viral infection 1 to 3 weeks before the onset, and usually it involves the upper respiratory tract. Guillain-Barré syndrome affects the motor and sensory pathways of the peripheral nervous system and the autonomic nervous system functions of the cranial nerves. The major finding in AIDP type Guillain-Barré syndrome is a segmental demyelination process of the peripheral nerves. Guillain-Barré is thought to be an autoimmune response to antibodies formed in response to a recent physiologic event. After the temporary inflammatory reaction stops, myelin-producing cells begin re-insulating the demyelinated portions of the peripheral nervous system. When remyelination occurs, normal neurological function should return. In some instances, the axon may be damaged during the inflammatory process. The degree of damage is responsible for the neurological dysfunction that persists after recovery. Symptoms include motor weakness, paresthesias, and other sensory changes, cranial nerve dysfunction, and some autonomic dysfunction. It begins with an abrupt onset of lower extremity weakness that progresses to flaccidity and ascends over a period of hours to days. Motor loss usually is symmetric, bilateral, and ascending. In the most severe cases, complete flaccidity of all peripheral nerves occurs. The patient is admitted when lower extremity weakness prevents mobility. Critical care unit admission is needed when weakness threatens respiratory muscles. The most common cause of death in patients with Guillain-Barré is respiratory arrest. As the disease progresses, intubation and mechanical ventilation are necessary. Frequent assessment of neurological deterioration is continued until the patient reaches the peak of the disease and a plateau occurs. The diagnosis of Guillain-Barré is based on clinical findings plus CSF analysis and nerve conduction studies. The diagnostic findings that are seen is elevated CSF protein with normal cell count. Break. The diagnostic finding is elevated CSF protein with normal cell count. Nerve conduction studies that test the velocity at which nerve impulses are conducted show significant reduction as the demyelinating processes of the disease suggest. With no curative treatment available, the medical management of Guillain-Barré is limited. The disease must run its course, which is characterized by an ascending paralysis that advances over 1 to 3 weeks and then remains at a plateau for 2 to 4 weeks. The plateau stage is followed by descending paralysis and return to normal or near normal function. The main focus of the medical management is the support of bodily functions and the prevention of complications. Plasmapheresis and intravenous IG are used to treat Guillain-Barré syndrome. IVIG has emerged as the preferred therapy because of convenience and availability. The nursing management of the patient with Guillain-Barré incorporates a variety of nursing diagnoses and interventions. The goal of nursing management is to support all normal body functions until the patient can do so on his or her own. Although the condition is reversible, the patient with Guillain-Barré requires extensive long-term care because recovery can be a very long process. Nursing interventions focus on maintaining surveillance for complications, initiating rehabilitation, facilitating nutritional support, providing comfort and emotional support, and educating the patient and family. Continuous assessment of the progressive paralysis associated with Guillain-Barré is essential to timely intervention and the prevention of respiratory arrest and further neurological insult. After the patient is intubated and placed on mechanical ventilation, close observation for pulmonary complications such as atelectasis, pneumonia, and pneumothorax is necessary. Autonomic dysfunction in Guillain-Barré syndrome patient can produce variations in heart rate, blood pressure that can reach extreme values. Hypertension and tachycardia may require beta blocker therapy. In patients with Guillain-Barré syndrome, immobility may last for months. The usual course of Guillain-Barré syndrome involves an average of 10 days of symptom progression and 10 days of maximal level dysfunction, followed by 2 to 48 weeks of recovery. Although Guillain-Barré syndrome usually is completely reversible, the patient will require physical and occupational rehabilitation because of the problems of long-term immobility. Recovery is a long process. Nutritional support starts early and is usually accomplished through the use of enteral feedings. Pain control is another important component in the care of a Guillain-Barré patient. Although the patients may have minimal to no motor function, most sensory functions remain intact, causing patients considerable muscle ache and pain. These patients also require extensive psychological support. Although the illness is almost 100% reversible, lack of control over the situation, constant pain or discomfort, and the long-term nature of the disorder create coping difficulties for the patient. Guillain-Barré syndrome does not affect the level of consciousness or the cerebral function. Patient interaction and communication are essential elements of the nursing management plan. Early in the patient's hospital stay, the patient and family must be taught about Guillain-Barré syndrome and its different treatments, as the teaching focuses on the interventions to maximize the patient's rehabilitation potential. The patient's family must be encouraged to participate in the patient's care and to learn some basic rehabilitation techniques. The importance of participating in the neurological rehabilitation cannot be overstressed. Okay, so that concludes Guillain-Barré syndrome, and we're moving into craniotomy. So craniotomy is performed to gain access to portions of the CNS, or the central nervous system, inside the cranium. Usually, this allows for removal of a space-occupying lesion. Common procedures include tumor resection or removal, cerebral decompression, evacuation of a hematoma or abscess, and clipping or removal of an aneurysm or AVM. Table 24.3 shows the different types of brain tumors occurring in adults, and then box 24.15 goes over the operative terms. Protection of the integrity of the CNS is a major priority of care for the patient awaiting craniotomy. It's essential to maintain adequate cerebral oxygenation, and seizure activity must be managed. Detailed assessment and documentation of the patient's preoperative neurological status are imperative for accurate postoperative evaluation. Preoperative screening tests are selected based on the procedure and the patient's condition. A blood type and cross match must be ordered, or it may be ordered. Perioperative teaching prepares the patient and the family for what is expected in the postoperative period. All craniotomy patients should avoid activities known to provoke sudden changes in intracranial pressure. Some of these activities include bending, lifting, straining, and the Valsalva maneuver. The patient undergoing transsphenoidal surgery requires preparation for the sensations associated with nasal packing. Psychological issues associated with the prospect of neurosurgery cannot be overemphasized. Few procedures are as threatening as those involving the brain or spinal cord, and then steps to meet the needs of the patient and the family include collaboration with religious and social services personnel, patient-controlled visitation, and provision of as much privacy as the patient's condition permits. The neurosurgeon must select a route that also produces the least amount of disruption in the intracranial contents. Neural tissue is unforgiving. A significant portion of the neurological trauma and postoperative deficits is related to the surgical pathway through the brain tissue, rather than to the procedure performed at the site of the pathology. Depending on the location of the lesion and the surgical route chosen, a transcranial or transsphenoidal approach is used to open the skull. In the transcranial approach, a scalp incision is made and a series of burr holes is drilled into the skull to form an outline of the area to be opened. A special saw is then used to cut between the holes. In most cases, the bone flap is left attached to the muscle to create a hinge effect. The dura is opened and retracted. After the procedure, the dura and the bone flap are closed. The muscles and scalp are sutured and a turban-like dressing is applied. The transsphenoidal approach is the technique of choice for removal of a pituitary tumor without extension into the intracranial vault. This approach involves making a microsurgical entrance into the cranial vault through the nasal cavity. The sphenoid sinus is entered to reach the anterior wall of the sella turcica. The sphenoid bone and the dura are then opened to gain intracranial access. After removal of the tumor, the surgical bed is packed with small section of adipose tissue grafted from the patient's abdomen or thigh. After closure of the intranasal structures, nasal splints and soft packing or nasal tampons impregnated with antibiotic ointment are placed in the nasal cavities. A nasal drip pad or mustache-type dressing is placed at the base of the nose to catch surgical drainage. So the figure that you see before you is a craniotomy procedure. A demonstrates burr holes that are drilled into the skull. B demonstrates the skull that is cut between the burr holes with a surgical saw. C is the bone flap that is turned back to expose the cranial contents. And then D is the incision after surgery where the bone flap is replaced and the wound is closed. This figure shows the transsphenoidal approach for surgery. During the initial postoperative period, management is usually directed toward the prevention of complications. Complications associated with craniotomy include intracranial hypertension, surgical hemorrhage, fluid imbalance, CSF leak, and deep vein thrombosis. Postoperative cerebral edema is expected to peak between 48 and 72 hours after surgery. If the bone flap is not replaced at the time of surgery, intracranial hypertension will produce bulging at the surgical site. Management is usually accomplished through CSF drainage, patient positioning, and steroid administration. Surgical hemorrhage after a transcranial procedure manifests as signs and symptoms of increased intracranial pressure. Hemorrhage after a transsphenoidal craniotomy may be evident from external drainage, the patient's complaint of persistent postnasal drip, or excessive swallowing. Loss of vision after pituitary surgery indicates an evolving hemorrhage. Postoperative hemorrhage requires surgical re-exploration. Fluid imbalance in the post-craniotomy patient usually results from disturbances in production or secretion of antidiuretic hormone, or ADH. Intraoperative trauma or postoperative edema of the pituitary gland or hypothalamus can result in insufficient ADH secretion. The outcome is unabated renal water loss even when blood volume is low and serum osmolality is high. This condition is known as diabetes insipidus, or DI. The syndrome of inappropriate antidiuretic hormone commonly occurs with neurological insult and results from excessive ADH. SIADH manifests as inappropriate water retention with hyponatremia in the presence of normal renal function. Leakage of CSF results from an opening in the subarachnoid space, as evidenced by clear fluid draining from the surgical site. When this complication occurs after transsphenoidal surgery, it is evidenced by excessive clear drainage from the nose or persistent postnasal drip. To differentiate CSF drainage from postoperative serous drainage, a specimen is tested for glucose content. A CSF leak is confirmed by a glucose value of 30 or greater. Management includes bed rest and head elevation. Lumbar puncture or placement of a lumbar subarachnoid catheter may be used to reduce CSF pressure until the dura heals. The risk of meningitis associated with CSF leak often necessitates surgical repair to reseal the opening. The patients who have undergone neurosurgery are at high risk for DVT development. These patients have a variety of additional risk factors, including preoperative leg weakness, Patients who have undergone neurosurgery are at high risk for DVT development. These patients have a variety of additional risk factors, including preoperative leg weakness, longer preoperative and postoperative stay in the critical care unit, longer operative procedure time, prone positioning on frames with flexion of hip or knees, longer time in the post-anesthesia care unit, more days on bed rest, lengthy operative procedures, and delay of postoperative mobility and activity. Clinical manifestations of DVT include leg or calf pain and erythema, warmth and swelling of the affected limb. The primary treatment for DVT is prophylaxis. Following neurosurgery, sequential pneumatic compression boots or stockings are effective in reducing the incidence of DVT. Low-dose unfractionated heparin or low molecular weight heparin may also be used prophylactically in high-risk patients once the risk of bleeding has decreased. The nursing management of the patient following neurosurgery incorporates a variety of nursing diagnosis The primary goal is protection of the integrity of the CNS. Nursing interventions focus on preserving adequate cerebral perfusion pressure, promoting arterial oxygenation, providing comfort and emotional support, watching for complications, initiating early rehabilitation, educating the patient and family. Frequent neurological assessment is necessary to identify problems and quickly intervene if complications do arise. Often a ventriculostomy is placed to facilitate intracranial pressure monitoring and CSF drainage. The head of the bed should be elevated 30 to 45 degrees at all times to control intracranial pressure. Other interventions include maintaining the patient's head in a neutral position at all times and avoiding neck and hip flexion. Hourly monitoring of fluid intake and output facilitates early identification of fluid imbalances. Urine-specific gravity must be measured if diabetes insipidus is suspected. Fluid restriction may be ordered as a routine measure to lessen the severity of cerebral edema, or as treatment for the fluid and electrolyte imbalances associated with SIADH, or syndrome of inappropriate antidiuretic hormone. Postoperative vomiting must be avoided to prevent sharp spikes in intracranial pressure and possibly surgical hemorrhage. Antiemetics are administered as soon as nausea is apparent. Early nutrition in the patient is beneficial, and postoperative fever may also adversely affect intracranial pressure and increase the metabolic needs of the brain, so an acetaminophen is administered orally, rectally, or through a feeding tube, and even IV. External cooling measures such as hypothermia blanket may also be used. Routine pulmonary care is used to maintain airway clearance and prevent pulmonary complications. If pulmonary complications do arise, consideration must be given to maintaining adequate oxygenation during repositioning. Pain management in the patient after craniotomy primarily involves control of headache. Small doses of intravenous morphine are used in the critical care setting. Oral analgesics should also be started as soon as can be tolerated. Non-opioid medications such as tramadol or toradol may be used as an adjunct medication. As opioid analgesics cause constipation, administration of stool softeners and initiation of a bowel program are important components of post-craniotomy care. Following neurosurgery, the patient is at risk for infection, corneal abrasions, and injury from falls and seizures. Potential infections include meningitis, cerebral abscesses, bone flap infections, and subdural empyemas. Care of the incision and surgical dressings is specific to the institution and the physician. Routine eye care may be necessary to prevent corneal drying and ulceration. Periorbital edema interferes with normal blinking and eyelid closure, which are essential to adequate corneal lubrication. After craniotomy, the patient may experience periods of altered mentation. Protection from injury may require the use of restraint devices, padding the sides of the rails of the bed, having a family member stay at the bedside, or the use of music therapy in rare circumstances. In rare circumstances, continuous sedation with or without neuromuscular blockade or barbiturate-induced coma may be necessary. Increased activity, including ambulation, is begun as soon as tolerated by the patient in the postoperative period. Rehabilitation measures and discharge planning may begin in the critical care unit, but are beyond the scope of this chapter. Transfer to a general care or rehabilitation unit is usually accomplished as soon as the patient is deemed stable and free of complications. Perioperatively, the patient and family should be taught about the precipitating event necessitating the need for the craniotomy and its expected outcome, the severity of the disease and the need for critical care management postoperatively must be stressed as the patient moves toward discharge. Teaching focuses on medication instructions, incisional care, including the signs of infection and the signs and symptoms of increased intracranial pressure. If the patient has neurological deficits, teaching focuses on the interventions to maximize rehabilitation potential. And the patient's family members must be encouraged to participate in the patient's care and to learn some basic rehabilitation techniques. The importance of participating in a neurological rehabilitation program must be stressed. So now we're going to get into a little bit of theory related to intracranial hypertension and the pathophysiology. So the intracranial space comprises three components: brain substance, which accounts for 80%, CSF, which accounts for 10%, and blood, which accounts for 10%. Under normal physiologic conditions, the mean intracranial pressure is maintained below 15, but I like to say actually less than 10. But if it's less than 15, it's still considered normal. The Monro-Kelly hypothesis proposes that an increase in volume of one intracranial component must be compensated by a decrease in one or more of the other components so that total volume remains fixed. This compensation, although limited, includes displacing cerebrospinal fluid from the intracranial vault to the lumbar cistern, increasing CSF absorption, and compressing the low-pressure venous system. When capable of compliance, the brain can tolerate significant increases in intracranial volume without much increase in intracranial pressure. But there is a limit to the extent of intracranial compliance. After this limit has been reached, a state of decompensation with increased intracranial pressure results. As the increased intracranial pressure rises, the relationship between volume and pressure changes, and small increases in volume may cause major elevations in intracranial pressure. The exact configuration of the volume pressure curve and the point at which the steep rise in pressure occurs vary among patients. The configuration of this curve is also influenced by the cause and the rate of volume increases within the intracranial vault. Regardless of how fast the pressure increases, the intracranial hypertension occurs when intracranial pressure is greater than 20 millimeters of mercury. So, as we see in the figure, intracranial pressure changes are most significant once the unit volume reaches the 8 mark and the pressure rises exponentially. But the pressure remains very stable from 0 to 5 or around 6 is when it starts to increase. So point A shows where the pressure pretty much remains normal with a particular increase in volume. And then point B shows where the increased intracranial pressure, as the volume increases, the intracranial pressure rises, but it's not so drastic. And then C, between B and C, is where you have this very, very sharp rise, and there's only a very small volume change. So I hope that makes sense to you all. This is a very important concept, and again, this concept is called the Monro-Kelly hypothesis. The normal brain has a complex capacity to maintain constant cerebral blood flow, despite the wide range in systemic arterial pressure, an effect known as autoregulation. So, autoregulation is that ability for the brain to maintain its blood flow within a very constant specific range, even when the blood pressure is outside the normal range. So, outside the normal, or outside the limits of this autoregulation, cerebral blood flow becomes passively dependent on the perfusion pressure. Factors other than arterial blood pressure that affect cerebral blood flow are conditions that result in acidosis, alkalosis, and changes in metabolic rate. Conditions that cause acidosis result in cerebral vascular dilation. Conditions causing alkalosis result in cerebral vasoconstriction. Normally, a reduction in metabolic rate decreases cerebral blood flow and increases in metabolic rate increase cerebral blood flow. Arterial blood gases exert a profound effect on cerebral blood flow. Carbon dioxide, which affects the pH of the blood, is a potent vasoactive substance. Carbon dioxide retention or hypercapnia leads to cerebral vasodilation with increased cerebral blood volume, whereas hypocapnia leads to cerebral vasoconstriction and a reduction in cerebral blood volume. Prolonged hypocapnia, however, especially at an arterial partial pressure of carbon dioxide, arterial blood gas exerts a profound effect on cerebral perfusion. Carbon dioxide, which affects the pH of the blood, is a potent vasoactive substance. Carbon dioxide or carbon dioxide retention, or also known as hypercapnia, leads to cerebral vasodilation, break. Arterial blood gases exert a profound effect on cerebral perfusion. Carbon dioxide, which affects the pH of the blood, is a potent vasoactive substance. Carbon dioxide retention, or hypercapnia, leads to cerebral vasodilation with increased cerebral blood flow, whereas hypocapnia leads to cerebral vasoconstriction and a reduction in cerebral blood volume. Prolonged hypocapnia, however, especially at an arterial partial pressure of carbon dioxide level lower than 20, can lead to cerebral ischemia. Low PaO2 levels, especially below 40 millimeters of mercury, leads to cerebral vasodilation, which increases the intracranial blood volume and can contribute to increased intracranial pressure. High PaO2 levels have not been shown to affect cerebral blood perfusion in either direction. The numerous signs and symptoms of increased intracranial pressure include decreased level of consciousness, Cushing's triad, diminished brainstem reflexes, papilledema, decerebrate posturing, decorticate posturing, unequal pupil size, projectile vomiting, decreased pupillary reaction to light, altered breathing patterns, and headache. Patients may exhibit one of or all of these symptoms depending on the underlying cause of the increased intracranial pressure. One of the earliest and most important signs of increased intracranial pressure is the change in the level of consciousness. This change must be reported immediately to the physician. In the patient with suspected intracranial hypertension, a monitoring device may be placed within the cranium to quantify the intracranial pressure. The device is used to monitor serial intracranial pressures and assist with the management of intracranial hypertension. An increase in ICP can decrease blood flow to the brain, causing brain damage. The monitoring device can also provide a sterile access for drainage of CSF. The type of monitoring and the monitoring site chosen depends on the suspected pathologic condition and the physician's preference. After intracranial hypertension is documented, therapy must be prompt to prevent secondary insult to the brain. The most current evidence suggests that intracranial pressure must be treated when it exceeds 20 millimeters of mercury. All therapies are directed toward reducing the volume of one or more of the components in the intracranial vault, and that would be CSF, blood, or the actual contents. of the brain. A goal of therapy is to determine the cause of the elevated pressure and, if possible, to remove the cause. In the absence of surgically treatable mass lesion, intracranial hypertension is treated medically. Close monitoring of the ICP and cerebral perfusion pressure should be done with customizing positioning to maximize the cerebral perfusion pressure and minimize the ICP. Positions that impede venous return from the brain can cause elevations in intracranial pressure. Positions that decrease venous return from the head must be avoided if possible. If changes to positions such as Trendelenburg are necessary to provide adequate pulmonary care, critical care nurses must closely monitor the intracranial pressure and vital signs. Some routine nursing activities do affect intracranial pressure and may be harmful, such as the use of positive end expiratory pressure, or PEEP. If it's greater than 20, then that can lead to harmful effects. Coughing, suctioning, tight tracheostomy tubes, Valsalva maneuver, and also if someone has suffered a trauma and is in a cervical collar, that may reduce the blood return to the out of the head or the cranial vault. Cumulative increases in ICP have been reported when care activities are performed one after another. Conversely, family contact and gentle touch have been associated with decreases in intracranial pressure. The current trend is to maintain a PaCO2 on the lower side of normal, roughly 35 plus or minus 2 millimeters of mercury, by carefully monitoring arterial blood gas measurements and by adjusting ventilator settings. Although hypoxemia must be avoided, excessively high levels of oxygen offer no benefits. The use of pulse oximetry has led to greater awareness of the circumstances such as pain and anxiety that can cause oxygen desaturation and thus elevate intracranial pressure. To avoid the increase in blood volume associated with increased cerebral metabolic rate, nurses must prevent hyperthermia in the patient with a brain injury. Antipyretic and cooling devices must be used when appropriate while the source of any fever is being treated or determined. So, maintenance of arterial blood pressure in the high normal range is essential in the patient with brain injury. Inadequate perfusion pressure decreases the supply of nutrients and oxygen requirements for cerebral metabolic needs. However, a blood pressure that is too high increases cerebral blood flow volume and may increase intracranial pressure. Control of systemic hypertension may require nothing more than the administration of a sedative agent. When sedation proves inadequate in controlling systemic arterial hypertension, antihypertensive agents are used. Care must be taken in choosing these agents because many of the peripheral vasodilators also are cerebral vasodilators. To reduce this vasodilating effect, concurrent treatment with beta blockers may be beneficial. Systemic hypotension should be treated aggressively with fluids to maintain a systolic blood pressure greater than 90 millimeters of mercury. Crystalloids, colloids, and blood products can be used depending on the patient's condition. Studies have demonstrated a positive effect on intracranial pressure and cerebral perfusion pressure with hypertonic saline. If fluids fail to adequately elevate the patient's blood pressure, the use of inotropic agents may be necessary. The incidence of post-traumatic seizures in the patient population with head injury has been estimated at 15% to 20%. Because of the risk of secondary ischemic insult associated with seizures, many physicians prescribe anticonvulsant medications prophylactically. Phenytoin is the recommended medication for seizure prophylaxis. Fast-acting, short-duration agents such as lorazepam may be indicated for breakthrough seizures until therapeutic medication levels can be achieved. CSF drainage for intracranial hypertension may be used with other treatment modalities. CSF drainage is accomplished by the insertion of a pliable catheter into the anterior horn of the left ventricle. This is called a ventriculostomy, preferably on the non-dominant side. This drainage can help support the patient through periods of cerebral edema by controlling spikes of intracranial pressure. One of the major advantages of the ventriculostomy is its dual role as a monitoring device and a treatment modality. Care should be taken to avoid infection. Figure 2411 shows the intermittent drainage system. An intermittent drainage involves draining cerebral spinal fluid through a ventriculostomy when intracranial pressure exceeds the upper pressure parameter set by the physician. Intermittent drainage is achieved by opening the three-way stopcock to allow CSF to flow into the drainage bag for periods 30 to 120 seconds until the pressure is below the upper set pressure limit. This is a picture of how a continuous drainage system is set up. And a continuous drainage involves placing the drip chamber of the drainage system at a specified level above the foramen of Monroe, usually at 15 centimeters. The system is left open to allow continuous drainage of CSF into the chamber, which drains into the collection bag against a pressure gradient that prevents excessive drainage and ventricular collapse. So now we're going to talk about some of the medical and nursing management related to increased intracranial pressure or intracranial hypertension. Osmotic diuretics and hypertonic saline have been used to reduce intracranial pressure. In the presence of an intact blood-brain barrier, hyperosmolar therapy is used to draw water from the brain tissue into the intravascular compartment. The direction of flow is from the hypoconcentrated tissue to the hyperconcentrated cerebral vasculature. If the situation becomes reversed, the tissue becomes hyperconcentrated in relation to the cerebral vasculature. A rebound phenomenon can occur. These agents have little direct effect on edematous cerebral tissue situated in an area of a defective blood-brain barrier. Instead, they require an intact blood-brain barrier for osmosis to occur. The most widely used osmotic diuretic is mannitol. Hypertonic saline, given in concentrations ranging from 3% to 23.4%, can also be used to treat increased intracranial pressure and may be just as effective as mannitol. In the setting, and I will mention that if you have a patient who has suffered significant trauma besides the head trauma, hypertonic saline may actually be the preferred choice because we will cause a volume expansion in the vasculature of the body as well. Whereas with osmotic diuretics, we'll actually cause a diuresis, and this will worsen someone with hypovolemic shock. Any treatment modality that increases the incidence of noxious stimulation to the patient carries with it the potential for increasing the intracranial pressure. Agents used to reduce metabolic demands include the use of benzodiazepines such as midazolam and lorazepam, intravenous sedative hypnotics such as propofol, opioid narcotics such as fentanyl and morphine, and neuromuscular blocking agents such as vecuronium and atracurium. These agents may be administered separately or in combination via continuous drip or as an intravenous bolus on an as-needed basis if the agents fail to blunt the patient's response to noxious stimuli. propofol or neuromuscular blocking agents may be added. If these agents fail to control the intracranial pressure, barbiturate therapy may be considered. The two most commonly used drugs in high-dose barbiturate therapy are phenobarbital and thiopental. The goal with either drug is a reduction in intracranial pressure to 15 to 20 millimeters of mercury, while a mean arterial pressure is maintained between 70 and 80 millimeters of mercury. Patients stay on high-dose barbiturate therapy until the intracranial pressure has been controlled for 24 hours. Barbiturates must never be stopped abruptly. They are tapered slowly over approximately 4 days. Clinical trials of barbiturate use have not shown improved outcome. The most common complications are hypotension, hypothermia, and myocardial depression. So now a bit about how intracranial hypertension can lead to herniation syndromes. Herniation of intracerebral contents results in the shifting of tissue from one compartment of the brain to another and places pressure on cerebral vessels and vital function centers of the brain. If unchecked, herniation rapidly causes death as a result of the cessation of cerebral blood flow and respirations. The four types of herniation are supratentorial herniation syndrome, and within that category we have uncal, central, or transtentorial, along with cingulate and transcalvarial. Uncal herniation is the most common herniation syndrome, and it's a unilateral expanding mass lesion, usually of the temporal lobe, which increases the ICP, causing lateral displacement of the tip of the temporal lobe. Lateral displacement pushes on the uncus over the edge of the tentorium, puts pressure on the oculomotor nerve, which is cranial nerve 3, and the posterior cerebral artery, ipsilateral to the lesion, and flattens the midbrain against the opposite side. Clinical manifestations of uncal herniation include ipsilateral pupil dilation, decreased level of consciousness, respiratory pattern changes leading to respiratory arrest, and contralateral hemiplegia leading to abnormal flexion or abnormal extension posturing. If no intervention occurs, fixed and dilated pupils, flaccidity, and respiratory arrest will occur. This is brain death. In central or transtentorial herniation, an expanding mass lesion of the midline, frontal, parietal, or occipital lobe results in downward displacement of the hemispheres, the basal ganglia, and the diencephalon through the tentorial notch. Clinical manifestations of central herniation include loss of consciousness, small reactive pupils progressing to fixed dilated pupils, respiratory changes leading to respiratory arrest, and abnormal flexion posturing progressing to flaccidity. Cingulate herniation occurs when an expanding lesion of the one hemisphere shifts laterally and forces the cingulate gyrus under the falx cerebri. Cingulate herniation occurs often. When a lateral shift is observed on the CT, cingulate herniation has occurred. Little is known about the effects of cingulate herniation, and no accompanying clinical manifestations exist to assist in the diagnosis. Cingulate herniation is not in itself a life-threatening condition, but if the expanding mass lesion that causes cingulate herniation is not controlled, uncal or central herniation is the extrusion will follow. Now, transcalvarial herniation is the extrusion of cerebral tissue through the cranium in the presence of severe cerebral edema. Transcalvarial herniation occurs through an opening from a skull fracture or a craniotomy site. So, quick question. Which type of supratentorial herniation is the most common? and you all would know that the answer would be D. Uncal herniation is the most common herniation syndrome. The two infratentorial herniation syndromes are upward transtentorial herniation and downward cerebral herniation. Upward transtentorial herniation occurs when an expanding mass lesion of the cerebellum causes protrusion of the vermis central area of the cerebellum and the midbrain upward through the tentorial notch. Compression of the third cranial nerve and diencephalon occurs. Blockage of the central aqueduct and distortion of the third ventricle obstructs CSF flow, and deterioration will progress rapidly. Downward cerebellar herniation occurs when an expanding lesion of the cerebellum exerts pressure downward, sending the cerebellar tonsils through the foramen magnum. Compression and displacement of the medulla oblongata will occur, which will rapidly result in respiratory and cardiac arrest. The two main causes of coma are structural and metabolic. Structural includes, well, actually, you know what, guys? We're going to be going into the summary here. And, well, I'm going to go ahead and go through the summary with you all and make some key points here, okay? So, the two main causes of coma are structural and metabolic. Under the structural category, we have ischemic stroke, intracranial hemorrhage, trauma, and then brain tumors. And then under metabolic, we have drug overdose, infectious diseases, endocrine disorders, and poisoning. Coma is the deepest state of unconsciousness. Arousal and awareness are lacking as a result of diffuse dysfunction of both cerebellar hemispheres or diffuse or focal dysfunction of the reticular activating system. Medical management focuses on identification and treatment of the underlying cause of the condition and support of vital functions. Nursing interventions focus on supporting all body functions, maintaining surveillance for complications, providing comfort and emotional support, and initiating rehabilitation measures and educating the patient and family. The sudden onset of an acute neurologic deficit persisting for more than 24 hours is known as a stroke, and it is caused by the interruption of blood flow to the brain. Strokes are classified as either ischemic or hemorrhagic. Hemorrhagic strokes can be further categorized as subarachnoid hemorrhage, which includes cerebral aneurysms and AV malformations, and intracranial hemorrhage. Nursing interventions focus on monitoring for changes in neurologic status, maintaining surveillance for complications, providing comfort and emotional support, initiating rehabilitation measures, and educating the patient and family. The two main causes of ischemic stroke are thrombus and embolism, and it results in a neuronal tissue injury from decreased or absent blood flow. The characteristic sign of an ischemic stroke is the sudden onset of focal neurological signs persisting for more than 24 hours. The signs depend on the affected portion of the brain. Medical management focuses on preservation of brain tissue through fibrinolytic therapy, management of blood pressure, and treatment complications. Subarachnoid hemorrhage is bleeding into the subarachnoid space, and it usually is caused by a rupture of the cerebral aneurysm or AV malformation. Medical management focuses on preservation of neurological function, support of vital functions, and treatment of complications such as rebleeding, vasospasm, hyponatremia, and hydrocephalus. Intracranial hemorrhage is bleeding directly into the cerebral tissue, and it is usually caused by a rupture of a small artery in the brain resulting from hypertension. Medical management focuses on preservation of neurological function, control of blood pressure, support of vital functions, and management of the intracranial hypertension. Guillain-Barré syndrome involves a rapidly progressive ascending peripheral nerve dysfunction leading to paralysis that may produce respiratory failure. Medical management focuses on support of vital functions and the administration of treatments to limit the duration of the syndrome. Nursing interventions focus on maintaining surveillance for complications, initiating rehabilitative measures, providing comfort and emotional support, and educating the patient and family about the disorder. A craniotomy is performed to gain access to portions of the CNS inside the cranium for the purposes of tumor resection or removal. Cerebral decompression, evacuation of hematoma or abscess, or repair of an aneurysm or AV malformation. Postoperative medical management focuses on preventing complications, which include intracranial hypertension, hemorrhage, fluid imbalances, CSF leaks, and DVT. Nursing interventions focus on positioning the patient's head in accordance with the physician's orders, monitoring the patient's intake and output, administering medications to control vomiting and fever, promoting postoperative pulmonary care, providing comfort and emotional support, maintaining surveillance of complications, initiating rehabilitative measures, and educating the patient and family. And finally, one of the earliest signs of increased intracranial pressure is decreased level of consciousness. The ICP can be measured using an intracranial pressure monitor, and it should be treated when it exceeds 20 millimeters of mercury. Medical and nursing management is directed toward reducing the volume of one or more of the components, which includes blood, the brain itself, or CSF, that lie within the intracranial vault. Herniation of intracerebral contents results in the shifting of tissue from one compartment of the brain to another and places pressure on cerebral vessels and vital function centers of the brain. If unchecked, it rapidly causes brain death. So that's the end of this lecture. I'm going to have one more lecture that's going to go over some of the key points of the neurological lecture. Thank you.